Thanks very much. My name is Carter Thorne. I'm a rheumatologist in Newmarket, north of Toronto. I run a community rheumatology practice, but have been quite involved in managing disease and working in RCTs, but also the privilege of working with my colleagues to develop the rheumatology framework that you're going to hear of today. Rheumatology, Canadian Rheumatology Association has the following mission statement, as people said. And our objective here is to present our biosimilar position paper and the development of it, to review the successes in collaboration, such as CLIA, and to describe the development of tools to facilitate those best practices. So we're going to hear some similarities and some resonance to what Laura was presenting earlier, less so to what Thomas has presented. So we are experts in arthritis care. That's our tagline. We're about 525 rheumatologists, if you include academic, community, and trainees. In Ontario, more than half the rheumatologists are community-based. Most of them are not hospital-based, so they're working on their own, similar to the challenges of support that Thomas alluded to, but in a different medium. And we support our members through the following areas. We're very active in this area. We've had the privilege over the past and the opportunity over the past 20 years of the new Canadian Rheumatology Association, because we've been an active organization since the 40s. But we've developed a framework recognizing the responsibility to provide active counsel based on best evidence and best practice, and I'll explain that in a few minutes. We are also committed to demonstrating responsible stewardship of therapeutic resources. And by this, I don't just mean medications. I mean all the resources that are required, the program, the product that Thomas was speaking of. We first engaged in the topic of biosimilars in 2011. We invited Health Canada to speak to a group of rheumatologists in Ontario. We were the only group that ever invited Health Canada to talk to rheumatologists or to talk to any professional group. And we've been engaged, the various members at both the provincial and the Canadian level in the concept of biosimilars and their development, so it has not come as a surprise. The CRA does appreciate that there is utilization and acceptance of biosimilars will continue to evolve, and that the position statement or any position statement has to be reviewed at least biannually, if not more frequently, as was indicated earlier. And that we are committed to collaborating with all the stakeholders, patients, prescribers, that's ourselves, payers, public and private, and pharma, to ensure that indeed we have the right medication for the right patient at the right time. And again, to emphasize, and I think congruent with what Thomas suggested is being done at the kids level, because we see that in rheumatology, but also we believe it's also something that should happen at all levels, ensuring real-world clinical effectiveness with an effective safety profile, and that's only through real-world studies. So we're talking about inflammatory joint disease. We're not talking about the other 130 reasons for saying ouch. We're talking about inflammatory joint disease. And we have this prescription of NSAIDs, prednisone, DMARDs, including especially methotrexate, as well as advanced therapeutic agents. And again, as was alluded to in rheumatology, we have been the trial area for most of biologic areas because there's enough patients with enough measurable outcomes that you can get those ends up pretty quickly. So fortunately, we have a number of different products with a number of different mechanisms of action, though indeed, a lot of them are TNFs that are available to us. And now we have these things called targeted small molecules, which are unique because they're developed to hit a target, whereas some of our products, such as methotrexate, came from another world, such as cancer therapy, used in different dosaging. We used a lot of borrowed agents in rheumatology. So there's been a big change, and I want to emphasize to you that there's a lot of things that have been going on together, and these changes occur, and that doesn't work. These changes occurred not only as the result of new therapies, but as a result of change in the therapeutic approach. And again, Thomas emphasized that, and I will as well. So at the same time that we developed, had the availability of biologic agents, there was an inflection point as to the use of methotrexate. So when we started using methotrexate in 75 to 80, it was 2.5 milligrams every 12 hours for 3 doses once a week. And there's now quite a variation in the use of it. Most often it's a starting dose of 12.5 milligrams orally, talking about effective therapy that Thomas mentioned, to another variation of 25 milligrams sub-Q given from day one. Most of the studies, however, are done with what I would consider, and many would consider, suboptimal dose of methotrexate, and no wonder some of the new agents work better than traditional therapies. Not only did we see this inflection point, but at the same inflection point, we see a decrease in the number of joints required for replacement. When the original biologics were tested, we'd see joint structural change that would occur in a number, I'll call it 10, in the placebo group, and it would be much less in the biologic group, call it 1 or 2. And now when we have the placebo group, we're seeing that change now of 1.8 versus the change in the treatment group of 0.8. I'll remind you the scale is 450. So we're talking about changes that are minimal and that a lot of opportunity has arisen by different approaches to care and using the treat to target. Canadian Rheumatology Association developed a guideline. I'll remind you that guidelines are to guide members, but also to be used for advocacy. And one of the recommendations is the use of methotrexate, unless contraindicated prior to the use of biologic, and there's variations. And again, the different formularies, whether private or public, came to be before we had any guidelines. So that's why there's discrepancy across the country, and why we advocated in the rheumatology world to try and bring a consistency across there. Already indicated the cost of these medications. Another problem that we have to deal with is the issues of terminology. And I attended a meeting here last month where we were given 3 different definitions of interchangeability. So there are definitions. Let's not spend too much time on it. We just have to understand what indeed we're trying to accommodate. We developed our first position paper in 2013, so that's a long time ago. I recall that we first met with Health Canada in 2011, position paper in 2013. So position papers are different. They're not to guide members, okay? They're really to inform stakeholders. So we want to be clear that that's what a position paper is. The Therapeutics Committee is mandated by the Board of Directors to develop a position paper, or sometimes they'll seek the mandate from the board. They identify content experts. So we have a very engaged group in our association, academic and otherwise, lots of expertise. And whatever it is, we try and get whatever is required for that particular issue, whether it's rituximab for vasculitis or uveitis and other agents, or in the case of this agent, this particular concept of position paper is looking at these activities. We also try and have regional representations because we're trying to ensure that there's this consistency across the country, though the professional organizations aren't as developed in all the provinces. That we then seek approval by the Therapeutics Committee, which is a standing committee. So again, lots of different people involved, and then approval by the CRA board, and then the provincial organizations, because again, that's where the rubber hits the road. So this is our position paper, has 7 points on it, and I'll just, they're listed here for you. So we believe that in naive patients, that a biosimilar is an appropriate agent to be used, might be considered. That we don't believe in administrative switch or interchangeability at the present time. It's not supported by the present evidence, but that might be different tomorrow. And I think Laura brought this forward. That substitutions from one biologic to another, including a biosimilar or an innovator molecule by someone other than the treating physician, should be avoided. We also brought up this concept of real-world evidence, that there should be an establishment of post-marketing surveillance. This should be done by a third party, should not be done by a CRO paid for by a company, because there's no sustainability in that. There are a lot of good surveillance and registry projects, and the kids do it very well because of their organization status. A little more difficult to do in the mix that we have, but not impossible. There's excellent projects in Quebec. There's one in Ontario, there's one out west, and then there's across Canada one, an early arthritis cohort. So these are quite established and can readily be developed. And indeed, the Ontario one, called the Ontario Biologics Research Initiative, was initially called for by the provincial government. The provincial government at that time walked away from funding it, so we were left to our own devices. We then figured that it was better to, in the longer term, strategically look at all practices, so we have a comparator group. So now it's called the Ontario Best Practices Research Initiative. And like Tom, I'm quite active in these groups. So in CATCH, of the 3,000 patients, we contribute about 350 of the 20 sites. And in the OBRI, of the 2,500 patients, we have about 400 patients in that group. So we actively participate in that because we believe that there is value to doing this. We also believe that all biologic molecules should be identified by an appropriate naming system. The system should be in place for that. That a biosimilar or an innovator molecule, and I think there's resonance here, they're all the same as far as we're concerned in terms of requirement to demonstrate safety and efficacy in a real-world environment, and that the role of the patient and the physician should be always considered. I bring forward two other initiatives that we've had and are striving towards to achieve this success. One was the first, that there were different requirements among private payers as to who was deemed appropriate to get a biologic agent in rheumatoid arthritis. So the Ontario Rheumatology Association initially, and then with the support of the CRA, approached CLIA, which is the Canadian Life Health Insurance Association, I believe is the acronym, to develop a new standard towards establishing the criteria for private payers. You understand we don't have provincial payers here because they're actually more difficult to engage. But to be clear, the CLIA told us that when we first approached them that this would be an impossible task, but nevertheless, there it is. We have an agreement across all groups. This does not tell a private payer what to pay for. It only says who is eligible. Okay, and so that's the next thing we're always trying to achieve is to make sure that there's a standard as best we can to avoid tiering, or at least to have some consistency. The other big challenge, of course, is people moving from province to province or from private to provincial payer. We've also been quite active because we realize that most of our providers and our prescribers are not in academic situations as opposed to the GI for pediatrics. And we've been encouraging different activities. I've already mentioned the 4 large provincial databases that we have. The members that are participating in those large provincial databases also have access to the administrative databases in those provinces. So what we've now attempting to do, and this is again supported by the CRA through its funding group, CIORA, to encourage the harmonization of how to define across those administrative data sets so that we can have a more robust group. Additionally, we're trying to say what is that core data set and how can we extract it from our charts in a fashion. So we've developed a minimal data set, which sounds easy, but it does require a lot of reflection. So here's the minimal data set that we have. And the next trick is to be able to extract that. So currently, as most things work in registries, you do your clinical exam, you try and find that information on a piece of paper, put it on another piece of paper, and send that piece of paper somewhere else so they can put it on a database. So what we're attempting to do now, again, funded through our organizations, not through pharma, but not directly through pharma, is to try and extract that non-intrusively, I should say, from our clinical data set, or EMR. In Ontario, 80% of rheumatologists are on an EMR, and 2/3 are using a single EMR. So we've worked with that particular vendor and developed the encounter sheets that have the minimal data set that can then just be faxed off or sent off or extracted via the web to get the data set that we can then look at clinical effectiveness as well as the adversity. So I think we're almost finished. So we have a lot of representation, a lot of consultation, trying to ensure, and we bring experts. And so again, we have a very collegial group from the academics to the community, from the leadership to ordinary members, and across disciplines as necessary. So the CRA is committed to ensuring best outcomes by advocating for evidence-based care and best practices based on real-world activities. We still see a significant variation. We just had our national CATCH meeting, that's the Canadian Early Arthritis Cohort, has about 3,000 patients across about approximately 20 sites. And we see, a little bit differently than Thomas stated, that there is a number of different ways to get to a good outcome. And what we've seen from the first CPV study, which was done about 4 years ago, where there was a significant variation in therapeutic strategies, there's also a significant variation in outcomes. What we see now is that those outcomes have come closer together, but there's still a significant variation in how they got there. So in our particular site, after a year, so remember, we've been collecting since 2007, so we're looking at the 1-year mark, so 2007 to 2008, if you started in 2008 to 2009, if you started in 2015 to 2016, our biolog penetration at 1 year is about 1%. It's as high as 80%. Remember that the outcome clinically using composite scores based on what you saw earlier is about the same. So there's probably a little bit of a difference in clinical efficacy, or should say effectiveness. The CRA is committed to taking a proactive lead as experts in arthritis care, and we believe, as Thomas suggests, it's not the molecule, it's the product, it's the model of care. And in particular, I think maybe perhaps you mentioned it, and Laura mentioned it as well, we're committed to new market, again, where we have this particular profile of therapeutic strategy, is a very sophisticated model of care, which for its cost of about $650,000 a year saves about $2.5 million if we were to amortize or annualize whatever the cost is towards having the same biologic penetration as other areas. So this is why I asked about gain sharing. If you can do that and you can demonstrate similar effectiveness, then you should be able to fund those processes to counter Tom's concern that you can't do this within the system. The program we have in Newmarket is funded within the system. It's the only one in Canada that has that kind of funding through some strategies, but it's one that we think is supported by evidence based on participation in these large clinical cohorts. So we endorse a collaborative approach involving members, those with arthritis, payers, both public and private, to ensure best outcomes.